webinar for 2022, and thanks for joining today. My name is Courtney and I'm based at the University of New South Wales at the National Drug and Alcohol Research Centre, and I'll be chairing today's presentation. Firstly, I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of the land where we are all based today. I'm on Gadigal lands, and so I'd like to pay particular respect to them and their elders, including present, past and emerging. So today we have the great pleasure of Professor Nick Zwar's company. Professor Zwar is the Executive Dean of the Faculty of Health, Science and Medicine at Bond University. And I was fortunate to have Nick at UNSW for many years, where he was previously Professor of General Practice and Deputy Dean of Education. Nick is an internationally recognised leader in health services research on prevention and management of chronic illness, with a particular key focus on respiratory and cardiovascular health. He has an illustrious career both as a leading academic in the field with over 200 publications, but also keen clinical insights as a practicing general practitioner. Today, we're very fortunate to have Professor Zwar put on his cap as the chair of the Royal Australian College of General Practitioners Smoking Cessation Guidelines, and Nick will be providing an update on new guidance on the role of nicotine vaping products in smoking cessation. Whilst we appreciate that the nicotine vaping product debate for smoking cessation has contrasting views, can I please ask that all members try to stick to the brief here? Remember, today we're exploring these products and their role in smoking cessation or quitting smoking. So I encourage, please, that we stick to the topic of cessation and their use. Also, just related to, do have the, sorry, just sliding through here. So a quick disclaimer that the views expressed within this webinar are the presenter's own and are not necessarily the views and opinions of APSAD. Just a quick disclaimer. And then I think we're ready now to go over to you, Nick, to provide your presentation. So I'll stop screen sharing now and pass over to you.
Thanks, Ryan, and thank you for the invitation to present. I'll just share my screen. Okay, can everyone see that okay?
Yeah, that's great, Nick.
Okay, so yeah, as Ryan said, I'm going to give an update about the guidance from the College of GPs about the use of nicotine vaping products for smoking cessation. And I'll just give a brief context first about the broader smoking cessation guideline that the college puts out and has been putting out for quite a number of years. So we've had some funding from the Commonwealth Government to update the guidance, and that's a two-stage process. So we did an update ahead of the October 1st deadline for the change in regulation of nicotine vaping products in Australia. And then we're doing a broader review of the guidance, the rest of the guide, in that timeline that you can see on the screen. But I'm really going to focus today on the nicotine vaping issue and its role in smoking cessation. We had a multidisciplinary group who took part in this. The expert advisory group, which I chaired, had people from general practice, public health, respiratory medicine, pharmacology, addiction psychiatry, Indigenous health, pharmacy, and people from the Therapeutic Goods Administration and from the Commonwealth Government Tobacco Control Branch as well. We were fortunate to have assistance from Emily Banks and her team from the ANU to actually provide some updated systematic reviews of evidence around the questions of interest. And to us, the particular question of interest was, what is the evidence on use of nicotine vaping for supporting smoking cessation? And we used a thing called the grade process, which many of you might be familiar of, where you look at the quality of or certainty of the evidence and you give that a rating. And then you make the expert group comes up to a recommendation based on that evidence. So it's a fairly formal process from the evidence review, the evidence decision tables, and then the recommendation. And I think in this area, which is so controversial, as Ryan pointed out earlier, to try to stick to the evidence and make that be I guess, the light on the hill that you try to reach, and your guiding principle was really important, because, you know, it is a very fraught area. It's an area where people have very strong views, and where arguments around other purposes for nicotine vaping colour that discussion about the role of cessation, or can be distractions from that main purpose we gave ourselves. So just a bit of definitional stuff, and, you know, nicotine vaping products is really, in the TGA definition, this is the one we use, therapeutic goods definition, that's the thing that the nicotine liquid in the vaping liquid, whether it's free-base nicotine or whether it's in a salt form, and whether it's in a pod or some other in a refillable device, it's the liquid that contains nicotine, and of course other things, sometimes flavorings, various things to make it help it aerosolize, like glycerin and propylene glycol, etc. And then the device that you use to deliver that is the nicotine vaping device. And of course, there's various models of that, as we all know, from the cigarettes to the tank models, and now the things like dual type products, the things that look like a flash drive, etc. So there's a range of things there, and they're changing rapidly, and that's part of the challenge. So we had a Pico question, a population intervention, a comparator and outcome. And the one that we thought was the most relevant for clinicians who were needing to make a decision and assess evidence and then make a decision was, are nicotine e-cigarettes any better or the same or worse for supporting smoking cessation than currently available pharmacotherapies? And unfortunately, the current evidence doesn't allow us to look at comparison to varenicline or comparison to bupropion, though I know those sorts of studies are starting to emerge. But the evidence such that it is really only comparing to nicotine replacement therapy. So that was our question. How does it compare with an existing therapy, and not comparing to placebo? I mean, that was done as well, but comparing to an existing therapy. And it's quite remarkable how little evidence there is from randomized trials. So this is from the review done by Australian National University, which has since been published, and you will be able to find if you look for it. That if you looked at nicotine e-cigarettes versus any concentration nicotine replacement therapy, there were 3 studies that met their inclusion criteria. And their inclusion criteria were based on at least 6 months of follow-up and a range of other quality indices. You'll find other studies if you look more broadly, but in terms of studies that they felt were of acceptable quality and where the outcome was measured in an acceptable way, there were only 3 studies. And that last one from Lee et al., which was done in Korea, in workplace situation, the concentration of the nicotine e-cigarette was very low, very, very low. So almost placebo level of nicotine in there. So when we asked them to look at, well, if you look for nicotine e-cigarettes that have a concentration of nicotine or deliver a concentration of nicotine, which would plausibly, provide a nicotine replacement therapy type effect, there's only in fact 2 studies, Bullen and the Hayek one. And the Hayek one, as you can see, is the much larger of the studies. That was done in the context of the NHS smoking cessation services in the UK, and had a year of follow-up. That one dominates the current literature, which is not ideal if you're doing systematic review. I mean, you'd like to have more studies, and you would prefer not for your conclusions not to really rely mainly on one randomized trial. So if you look at that forest plot, the Bullen one yes, there was a small benefit of 1.26, in the risk ratio, but you can see the 95% confidence interval of that crosses 1, so it crosses a no effect line. But when you have the HIAC study being so much larger, and therefore the confidence intervals being narrower, you come to that overall view that yes, there is a benefit of nicotine e-cigarettes versus standard NRT, and a risk ratio of 1.67. So, not a major effect, but a worthwhile effect. And remember, this is compared to monotherapy NRT. It's not, well, though in HIAC they did offer them combination therapy, though not everyone used it. So there's a whole lot of issues there too. But, it isn't a lot of evidence to go on. So the evidence quality was rated as low, as you can see, by the ANU team, and the expert advisory group agreed with that rating, but there was some evidence. So this is our evidence decision table, which we looked at. So you can see 1,468 participants from the 2 randomized trials, quality of evidence on the grade criteria low. There's that relative effect showing a benefit. And so if you were thinking about how many more people might quit smoking due to that intervention versus this intervention, you might say it's probably around 55 people more per 1,000 who got the treatment. But there's quite a range in that. The confidence intervals around that from 17 more to 105 more. But, it appears that there may be a benefit based on that systematic review of just 2 studies. But as I said, not a lot of evidence. And then we came to our recommendation, and this one, of course, has received quite a lot of press attention and attention in the smoking cessation world, and has been interpreted in a range of ways by a range of people. We came to the view that this is not a first-line therapy. There's no nicotine vaping product that's been through a full medicines assessment anywhere in the world at this point. So we don't have good quality evidence on safety. And when you look at long-term safety, particularly of nicotine e-cigarettes, we just don't know. And there's even concerns perhaps about short-term safety at some points. And so there's lots of reasons why they wouldn't be first-line therapy if you had an option that had been through a full process. But if you had someone who'd not succeeded using a first-line therapy, and you thought they'd given it an adequate go, and they'd like to quit smoking, and then nicotine vaping products might be a reasonable intervention to recommend. But you would need to have an evidence-based discussion if you're a practitioner like myself, who was having, and others on this call who are having those sort of discussions with patients, where you looked at the pros and cons, the lack of long-term safety data, that they're not registered therapeutic goods, and therefore we don't know a lot about those things that I mentioned, the lack of uniformity, and that's an issue too, increases the uncertainties, that we really need to avoid dual use, so people continuing to smoke and using nicotine vaping products, because very unlikely to get the health benefits if that's the case. And we want to avoid long-term use because we do not know about safety, and we'd like people to be nicotine-free or as well as tobacco-free. And important to have regular review and monitoring to try and follow through and encourage all those things happening, that people do stop smoking and then they do stop nicotine vaping as well. And you can see we came to a conditional recommendation for the intervention with low certainty. Now, having said that and made that recommendation, there were a whole sort of range of practical issues which arise in the context of the unique Australian position, where we've got from the 1st of October last year, the TGA are saying that nicotine vaping products can only be legally available on a prescription from a medical practitioner or a licensed prescriber, and yet we don't have a registered product. So you need to think about the pathway by which you might prescribe if you choose to, the practicalities of that, the dosing considerations, the device considerations, and issues that to do with other things in the nicotine liquid in the vaping product, such as flavourings, and what you might do to try to minimise potential harms. Important to say, given all that context and uncertainty, we wanted to make it very clear in what we're saying to practitioners that we could well understand, or anyone could well understand, that some people may just not wish to prescribe nicotine vaping products in that context. They might think there's just too much uncertainty, there's too much risk, there's too little evidence of benefit, I don't want to get involved in this. And that would be completely understandable and a reasonable conclusion that people might come to. But if people do want to offer that service to their patient because they think there is a potential benefit there, and people have not succeeded in quitting with the currently available therapies, and the currently available therapies we all know are not by no means 100% effective, and even with our best efforts of combining nicotine replacement in combination form or varenicline with behavioural support, we're probably, if we have 20% of our patients successfully quit a year later, we've probably done pretty well in the real world. And in trials, it's a bit higher, maybe 30%. But, it's not like we have any form of treatment for tobacco addiction, which is, 80 or 90% effective. We're a long way away from that. So, there is a argument for trying to find things that will help people beyond what therapies we currently have available. So the risks, I've said most of this, I won't go through it again, but I probably just highlight a couple of points. One of the things which worried us a lot, and I'm sure worried many people on this call about nicotine e-liquid, is the risk of accidental or deliberate ingestion. And as most people would know, we've had a death of a young child in Australia due to ingesting nicotine liquid that was in the 100 milligram per mil concentration, so that very high concentration, and in the process of dilution, that a child managed to get hold of a bit of that and swallow it, and unfortunately tragically died. So it is very toxic, and only small amounts can be lethal, particularly to children. And there's a whole lot of other risks there. You could get the dilution wrong, etc., as well. And then burns, the high concentration things are irritant to skin. There's risks of some, very occasionally, the devices exploding, due to electrical faults, etc. We talked about dual use, long-term exposure to nicotine, possible diversion leading to use by non-smokers. This was something that came up quite a bit in discussions. What about uptake of nicotine vaping in young people and not non-smokers, but including not young people, and how would the risk of diversion be minimised in the application of this new regulatory framework? Promoting nicotine use through vaping, and then perhaps renormalising smoking, and that concern about the gateway effect. And again, going back to the ANU work, they've recently published some analysis of that, and they came to the conclusion that use of nicotine e-cigarettes by non-smokers is associated with a tripling of the risk of initiating combustible tobacco use and becoming a current smoker. Now, I'm sure there's people on the call who wouldn't agree with that assessment of the evidence, but that was the conclusion they came to in their recent systematic review, a tripling of risk if non-smokers start to use nicotine vaping, that they will become a smoker of tobacco. So that is a significant issue. Clearly, it's a significant issue. Nicotine exposure in the adolescent brain, young people using nicotine, and there's concern about brain development and medico-legal risks. If you're a prescriber, obviously you need to think about your medico-legal responsibilities and risks. Now, this is the TGA process, and I guess the reason for putting this up is that there's 3 different ways by which someone might be prescribed, given a prescription to get a nicotine vaping product: the authorised prescriber, the special access, and the personal importation. And when in the expert advisory group, we looked at those 3 different pathways, we were strongly of the view that the safest one is the authorised prescriber scheme, because only under that scheme do all of the, all of the requirements of TGO 110 apply to the nicotine vaping product that the person would get. You could not be certain that all of the TGA 110 requirements would apply if you were writing a script and then giving it to someone for them to import through the personal importation scheme from an overseas manufacturer. You wouldn't necessarily know that it completely met the TGO requirements. And those include things like describing the concentration accurately, warning labels, childproof containers, etc. There's a range of things which you can look up, which TGO specifies, and which are important to safety. But if you do it through the authorised prescriber and it's supplied through an Australian pharmacy, then both the pharmacist and the pharmacy supplier, so or company that provides the product to the pharmacy, have legal and good practice requirements on them to make sure that things comply with those rules, and that the product the person gets is fully compliant with the standard. Another practicality which I think is important is, what kind of nicotine delivery device do you use, and that has implications for what sort of nicotine vaping product you might prescribe. The open system, the open tank systems where people refill, perhaps diluting and then refilling, diluting their nicotine vaping liquid and then putting it into the device, have risks in that the dilution process, errors can be made. There's the risk of accidental ingestion, as I mentioned earlier, and people can add other things to the liquid. And that, we saw with the Valley outbreak in the US, that if things like vitamin E acetate are in the liquid, then that can have devastating effects on the lung. And so that potential for other things to be added that may be toxic can be reduced, actually eliminated, if you give a closed pod device as your prescription. So if you only prescribe nicotine vaping products in the closed pod system, you eliminate that problems or those problems. Now you have another set of problems that come along, but at least you eliminate those ones. The nicotine pods are all nicotine salts, and it's important to say that none of those trials that I showed earlier were done with nicotine salt. They're all done with nicotine freebase. So there isn't a study published as yet which has looked at the efficacy of nicotine salt in producing cessation and compared it to nicotine replacement therapy or anything else. Having said that, the same nicotine, whether it's freebase or nicotine in the salt form, nicotine is the active ingredient. So though the chemistry is slightly different, the end chemical that is having the effect is the same. So there would be reasons to think that nicotine salts should be as effective, but we haven't got empirical evidence of that at the moment. And of course, existing users will have preferences, and that's another factor that can make life challenging for the prescriber. We suggest don't prescribe over 20 milligrams per mil if you are prescribing nicotine freebase, because anything over 20 milligrams per mil is likely to need to be diluted, or will need to be diluted. And then that creates those issues I talked about with errors. And our view was that 20 milligram per mil should be adequate in the freebase form to get the benefits of smoking cessation. In those studies, both of those studies, or all three studies, were using concentrations lower than that to get those the benefits that we saw. I've said that there's no clinical trials at the moment on the nicotine salts. We thought that it was preferable to not give people a large quantity at any one time, so that there was, to do for several reasons. One is to reduce the risk of diversion. Another would be to ensure, or try to ensure, that your patient came back for follow-up, so you could actually discuss how they were going and talk about, how they were going to stop vaping, making sure they're not both smoking tobacco and vaping, etc., giving them follow-up support, behavioural support for smoking cessation. And where possible, avoid flavours completely, though there's not many products that, that if you're doing a pod, they usually have a flavour already in the pod, but reduce that as much as possible. And of course, people often go to vaping shops and buy different flavours. So you're probably reducing that if you use you are reducing it if you use a closed system, because at least you know that they're not going to have extra flavours added beyond what comes in the manufactured nicotine salt pod. I guess the other thing I should have said there, and maybe, is we were strongly opposed to the disposable devices. And for several reasons. One is that the quality of their manufacture is quite problematic. They have a wick that the nicotine is soaked in, or a wick has the nicotine that comes up against the heating element directly. So you can get some burning of the wick, and that could create a whole lot of potentially toxic products of combustion if there's some degree of burning of that nicotine-soaked wick. They also have a battery in them, and then when they dispose of them, they're disposing a battery, which is not great for the environment, or more than not great. It's really problematic for the environment, and they are variable in the amount of nicotine they deliver, but they tend to be pretty high dose. And in some analysis that's been done by, I think it's the University of Wollongong, they looked at what they contained, and I think almost all of the nicotine disposables they looked at had a particular chemical which is there to make it less harsh on the throat, and has been used by the tobacco industry to encourage young people or people who haven't smoked before to not get throat irritation related to initiating use of tobacco. And why is that product there? One would wonder if the motivation is to encourage use by previously nicotine naive individuals. So strongly opposed to their use, and would not be encouraging anyone to prescribe those. Then MVPs in specific groups. Clearly people with long-term illnesses, though there isn't data at the moment in particular subpopulations, one would think that, you know, if people have long-term illnesses like heart disease or asthma or COPD, if you can help them to stop smoking, then there's very clear evidence of benefit for their disease. So, you know, you wouldn't rule this out, but there's an absence of specific evidence. Aboriginal and Torres Strait Islander people, clearly higher rates of smoking and a major contribution to the gap in health outcomes in Australia. So a group where, again, we don't have data, but if people have not succeeded with current methods, one would think this may be a helpful thing. People with mental illness, again, high rates of tobacco use and often difficulty in quitting and need for more intensive follow-up. But again, if people have not succeeded with the therapeutically approved medicines, they might be a reasonable group. Not advised, in fact, we recommend strongly against use in pregnant or breastfeeding women, particularly in pregnancy, but we also extend that to breastfeeding, and not to be used in adolescents, given the lack of data and the concerns about nicotine in the adolescent brain. So we're some way off having evidence to help us in that population group. And then very important, as I said, to get some follow-up and some to try to provide that support that would help people to quit successfully. And by that, I mean quit both tobacco and the vaping product. And the titration of the dose might be needed. It might be that people are not getting enough nicotine to keep any withdrawal symptoms at bay, or they might be getting too much and need to have a less lower concentration device, or think about how they use the device. One of the challenges here is that the amount of nicotine that a nicotine e-cigarette delivers, the amount of nicotine that will get into the bloodstream and therefore to the central nervous system, is related to, yes, the concentration of the nicotine vapor liquid, yes it is, but that's only one factor. It's also the device and the power of the device, so the power, the heating element and the electrical power of the device, and the topography of the vaping. So how often people puff on it, how much they draw the vapor into their lungs, that all those things combine in a complex way to determine the amount of nicotine that's actually delivered. And so you can't say, oh, well, because this, nicotine liquid is 20 milligrams per mil or whatever it might be, you will get this much in the bloodstream. If you take a higher concentration nicotine salt device, say something that's 50 milligram per mil or something of that order, it may be that people don't inhale it as deeply as often, so they end up with a similar nicotine concentration in their blood, but less of the other things that come with it. In terms of the other molecules in the vaping, in the vapor. So it's difficult to say exactly how much will be delivered, both in nicotine and other inhalants, because there's a number of factors involved. Complete transition from nicotine vaping products to combustible tobacco. So stop combustible tobacco and completely change over to this form of nicotine replacement, because ultimately they're another form of nicotine replacement. And then how do you titrate off? Evidence-free zone, and we don't know, but our suggested approach was similar to what you might say for nicotine replacement therapy, to think about 12 weeks or something like that of use, and then to be withdrawing the nicotine vaping product, based on the experience with nicotine replacement therapy in all of the studies that have been done of that, and the small number of studies we've got of NVPs. But it is somewhere where a lot more research is needed. And I know there are different approaches to how people might transition off nicotine vaping products, including perhaps changing people over onto patches and then off completely, because you would get probably a decrease in nicotine delivery when you go from a nicotine vaping product to a patch, and then from a patch to nothing. We're kind of used to that transition from our previous experience with nicotine patches over many years. Tobacco relapse prevention. As I've already said, the ideal and the gold standard and what we're aiming for is cessation of both tobacco and use of nicotine in other forms. So our concentration in the guideline was not about long-term use as a harm reduction approach. It was about help using nicotine vaping products for smoking cessation, and then people stopping using the nicotine in the vaping product form as well. And that if you're having that discussion, think about other forms of pharmacotherapy, which we already have, which might have a role to play here to assist. Now, there's a range of questions, and maybe this will lead into the discussion, which are, I don't have the answers to all of these by any means. And the expert advisory group decided it would meet some months after the 1st of October implementation to try to get a sense of and look at some data on what's happened since that transition to the new regulatory framework. And this is a unique regulatory framework around the world. No other country has yet gone down the road of making nicotine vaping products a prescription only availability, and seeking to use that interaction between a health practitioner and an individual to see these products used to support cessation, but not as a sort of recreational availability. As you know, over-the-counter or direct-to-consumer is the case in US, Canada, the UK, and sort of New Zealand as well. Their situation's evolving. So we've set a set of questions to the TGA. I haven't got the answers to these yet. We know that there's about 620 people, probably a bit more than that now, who in February this year were authorised prescribers around the country. Only 100 and something of those have chosen to have their names listed on the TGA website so that the public could find them if they're looking for a practitioner who had gone through that authorised prescribing process and applied for that approval. We don't know which pathways are currently being used most often, whether it is authorised prescriber or whether it's personal importation or whether it's a special access scheme. We don't know yet what sorts of NVPs are being prescribed, whether it's the nicotine-free base in the liquid form, what concentration, or whether it's mostly in the salt form, etc. We'd really be interested to know what's happening in terms of enforcement of the requirement to attach a prescription if you're doing personal importation, and how effective is that? Is the Australian Border Force able to detect and seize importations that don't have the prescription attached? Don't know the answer. There was an MBS item introduced on the 1st of October as well that allows practitioners to do a face-to-face or telehealth or online consultation for smoking cessation. That item exists. We'd be very interested in the data on how much is it being used and how many people are using it. Is it a broad thing across lots of practitioners, or is it concentrated in a small number of practitioners who are making use of it, that item? And is there any evidence of diversion of NVPs to non-smokers? So is there any evidence that nicotine vapor products prescribed by medical practitioners are being diverted to non-smokers, or not the person who's not the person they were prescribed for? Because they were some of the concerns which worried us at the time, and were uncertainties and remain questions that we haven't got clear answers to, but obviously important. You know, I hear, as I imagine many people on this call hear, that, and sometimes see with their own eyes, that nicotine e-cigarettes remain widely available in consumer outlets, though it's not legal, and that the disposable devices remain widely used, and in fact, anecdotally, even more used. And that is a problem in schools, and it's a problem with, you know, in all sorts of contexts. So, you know, one wonders about the effectiveness of enforcement when that seems to be the case. But we don't have, to my knowledge, and some people on this in this webinar may have insights here, good data on that. I know there's soon to be something published from Cancer Council New South Wales, which is looking at some of these issues, and that will be of help. And a number of us are involved in research projects. We're trying to examine some of these issues as well. But we certainly need further information to try to ascertain how successful or otherwise this change has been, and whether there's need to make further changes to the policy. At one point, the personal importation method was going to be closed off, and talked about that having a sunset clause. I haven't heard anything further about that, whether that is going to be the case, and one would, I guess, with an upcoming election, it's not going to happen, certainly before in the current electoral cycle, one would think. So there's lots of issues and lots of things to think about. Probably all of you have probably seen the guide, and that's just the website address. If you want to look at the nicotine vaping module, it's on the college website. So I'll stop there, and we've got a bit of time for questions.
Thanks so much, Nick. A very comprehensive presentation. I'm sure particularly all our audience, in particular the health providers and professionals, would really welcome all this information. So just to open off with the panel here, I'll also be joined by Dipala, who's also the co-chair of the APSAD Smoking Cessation Professional Group as well. But the practicalities, I mean, with the guidelines, Nick, as a conditional recommendation, how do you generally have that discussion and then work from a practical level? Obviously, you know, articulating the risks and maybe potential benefits if they have used and failed with previous treatments before, and how do you work through that process to actually, you know, learn that process of how to prescribe? A doctor might not know how to prescribe in the first instance, and then know all that much about the TGA 110 standards and which products to use. So how did you go through that process yourself as a general practitioner? But what advice could you give to others about how to approach that conversation, but then also make sure they're informed and the general practitioner is also well informed about all the different computations here?
Well, good question, Ryan. I mean, I think you probably need to do a fair bit of reading and thinking before you write your first script. You know, and certainly, you know, the RACGP guide, you know, I've talked about is one source of information. The new Quit Centre, which Victoria has just established recently, has some very useful resources. The TGA website has some good stuff as well, and particularly about pathways to become a prescriber. So, you need to do a bit of reading, a bit of thinking. You also need to you're meant to have a consent form too. You've got for patients if you're doing that via the authorised prescriber pathway. So you need to create a template for that and have it on your practice software and ask people to consent to that. That's in the kind of fine print of the authorised prescriber requirements. So getting yourself prepared, having, in a practical sense, having designated consultations that people can book for this, only do it in those. So you're not getting, surprised by someone coming in and asking at other times. So you've got yourself sort of set up and ready for a certain number of consultations per day or per week or whatever you want to do it. That's just a way of managing the workflow and the challenge, because it takes some time, and you don't want to be at the end of a consultation about something else. Oh, doctor, can you prescribe me my nicotine vaping, please? When there's to have a whole proper evidence-informed discussion.
Yeah, okay, yeah. And I noticed a few questions that did come through before today's presentation. There's a couple here from Tracy Greenberg, and thanks, Tracy, for your comments. I think, Nick, you can look into the future, and you've already answered the first question about what we know about whether or not prescriptions are coming locally or whether or not they're through the personal importation scheme. And from what you said in the presentation, it sounds like we just don't know that yet.
Well, I don't know it yet. I mean, there's someone on the call does, but that's a question that the TGA should know. I mean, they would have that data, because when you're an authorised prescriber, well, no, with an authorised prescriber, you have to report every 6 months about how many people you prescribe for, and so they would have data every 6 months on that. Now, whether they can also get data from pharmacists about things coming in via border force, via the borders, may be more difficult. They would have data, will have data on the number of prescriptions via the authorised prescriber route and the number of people, the individuals, the number written by each individual prescriber. Because it'd be interesting to see, and we're all aware there's some online prescription services, whether the bulk of prescribing is being done by them or what's the distribution of the prescribing.
Yeah. And then we've also got a comment or question from Tracy around access to vaping now with the emergence of a lot of more online vendors and outlets. You could call it, telemedicine in a sense, but she asked, how does the RACGP view the so-called health business, these websites? And I think from when I last looked, there looks like there's more than 10 now listed on the TGA website there. But how does it allow for members of the public to apply for a prescription without actually seeing a doctor face-to-face or even via the phone? So there's some concerns there around, that model that's not quite the traditional face-to-face one and the prescribing practice. What are your thoughts on that?
Well, I can't speak from an official RACGP position on this, but I can say what my thoughts are individually. I mean, good practice is to obviously assess your patient and the benefits, the risks, all those things I've talked about. And I think it would be possible to do that in an online consultation. Preferably one with not just by phone, but with a video. But I am aware, as I'm sure Tracy is and others, that some of those services, and I'm not necessarily saying it's the ones listed on the TGA website, people are not getting a consultation with a doctor. What they're getting in some services is they send in some information some process happens. To what extent it's reviewed by a medical practitioner, one doesn't know. And then they receive a script in the mail. Now, I can't see how that's consistent with good practice, and I can't see how it's consistent with the expectations of a prescriber broadly for any medicine, so that is problematic. And I think, the TGA have taken some action against some of the entities. And so I think if people are aware of practice which seems substandard or they believe is substandard, I think it's a good idea to inform the TGA of that. There have been some fines issued against some of the behaviours that we've seen since the listing.
Okay, great. Yeah, thanks for that response, Nick. And then I think during your presentation, and this relates to a comment that Renee has asked that I'll expand upon in a sec, but some of the limitations with some of the current trials is that they've rarely or ever used 20 milligrams per mil or more nicotine delivery, and pod devices haven't necessarily been evaluated in a clinical trial setting at higher dosing. So, and then Renee talks about the concept of nicotine flux. So she just sent an article that was published in Nicotine Tobacco Research. So what can be done to control, I guess, the nicotine delivery so it benefits smokers, but then also that inadvertent consequence that can happen with, as you said, a child potentially getting access to it, hopefully with the new standards with the TGA 110, they now specify with childproof capping and safety features. But how do we, as a profession, make sure the nicotine delivery is there, but then also be cautious of these really important considerations that can come into play?
Well, it seems to me that the best answer would be that we had nicotine vaping products which were licensed medicines that have been through the full process of assessment for efficacy and safety that you'd expect of nicotine replacement patch or gum or lozenge or mouth spray, whatever. And nowhere in the world, as I said, has that happened. If it's going to happen anywhere, it could well be in Australia because, we've got this unique regulatory environment. But if such products were available, then they would be the ones which we would use, in my view, and other things that didn't have that assurance, you would ban, and you would, make sure, do your best to do what we do with illegal tobacco, and you try to have ways of controlling access. So I haven't got a good answer to Renee's question, because I think there will be inevitably developments in how nicotine is delivered from people who are looking to change the product, make it more attractive, all of those sorts of things, and they will just continue because it's a consumer environment and people are looking to sell a product. And as you're probably aware, in the United States, there's a bit of a loophole in the FDA regulations. Things that are so-called synthetic nicotine aren't covered by some of their current regulatory frameworks. So people have seen a way to sell vaping products which are so-called synthetic nicotine. It ends up being nicotine, but because there are variation on the molecule, it's not caught up under the FDA's currently regulatory framework, which specifically mentions nicotine. So that's an example of how people will try to get around regulation, seems to me, in the consumer market. So that's, I don't know how you prevent that unless you have a licensed medicine.
Okay, yeah. And the complexities of licensing a medical device, yeah, it's a different ballpark when you're comparing against the traditional NRTs of gum and lozenge and that, compared to these devices that have many things that heat as well, which is so complex. Yeah. So Sean Pritchard has a question here. How do you calculate the amount to prescribe against how much people smoke to then measure reduction as time goes on, please? Thank you.
A really good question, and the short answer is no one really knows. You know, there are some suggested ways of approaching that, which are in the guideline we've got, and the TGA put something out too, based on a document produced by University of Wollongong. I mean, you basically need to decide on a starting dose, and that will be based on your assessment of the person's current level of nicotine dependence, and then titrate up or down. And you probably want to do the titration, you know, not too long after they start on the medicine, or call it medicine, because that's how we're seeing it here, like a week later, like you would with, you know, nicotine replacement therapy. But it will depend on your patient. I mean, probably for an older person who doesn't weigh very much, you'd be choosing a lower concentration sort of product. I mean, as I said, if I was using free-base nicotine, I wouldn't ever go higher than 20 milligrams per mil. And as a starting dose, I might go like 6 or 8 milligram per mil in someone who was smoking 15 a day or something like that. And then I might titrate up to 12 or something of that order, maybe even to 18, though less, sort of not many people would need that. That's kind of a bit of an idea. So, you know, in the free base, starting dose of 6 or 8 milligram per mil is pretty typical. But yeah, I'd probably look up the guide because it's got a bit of a table there to try to help.
Okay, great advice there, Nick. And then, so I've only got next to about 1 minute left. So Nikari Ferguson had a question related to the vaporized nicotine products. So I know they need the labeling for TGO 111, but is the labeling accurate?
Well, look, one of the parts of the labeling is about that the concentration of nicotine is accurate, and I think if you are, the best way to think that you could have confidence that it was accurate, as I said, would be to prescribe only a product by the authorised prescriber, and to specify on the script or by sending it direct to a pharmacy that it is provided through an Australian pharmacy. Because then the pharmacist and the pharmacy wholesaler need to do their due diligence about whether the product actually does meet all those requirements, including that the nicotine concentration specified on the product is accurate. And that would be your best way of having confidence, as much confidence as you can, that yes, you are giving 20 milligram per mil or 18 milligram per mil or whatever. And there are certain things that are not in there. Some of the prohibited things that can be in the nicotine vaping liquid are not present in that, because there's a few particular molecules which are banned under TGO 110 that can't be there because they're known toxicity. And so that would be the best way of having confidence that that was accurate.
Okay, thanks. And then just we'll just throw to the wider panel now. I saw Dipali in the chat. Yeah, fire away.
Thanks, Nick. Thanks for the comprehensive presentation. It's very helpful and useful. So how would you summarize this evidence as a limited evidence or mixed evidence for vaping?
Well, it's limited. I mean, as I said, there's only 3 trials that met the criteria that the ANU used, and only 2 of them were had using nicotine vaping products that had sufficient nicotine to think they might be efficacious. It's a very small body of evidence, and I am surprised. I'm sure everyone is that there aren't more studies. I mean, it's remarkable that there aren't more studies for what's such an important therapeutic question. So let's hope we see more in the reasonably near future.
Great. Thank you very much for that. That's all from me there.
All right. Well, Nick, I think it's been fantastic to hear from you, and I think welcome fresh air. I think with the guidelines, you know, more recently being implemented and having an outlet here today for practitioners, health professionals to be able to hear from you as the chair is just great. So really appreciate your time and wishing everyone a lovely rest of the week.
Thanks, Ryan.
Thank you, everyone. Bye.